aid while sustaining outcomes, global health initiatives and new development agendas. So, Sara, we're very much looking forward to your talk, and as you're aware, this seminar will be live streamed, so I'd just like to welcome any viewers online as well. So, Gary, if we're ready, then yes, thank you very much.
Thank you very much, Nick. And it's a pleasure to be here, and thank you all very much for coming. As Daniela and Lydia both indicated, this is something that we've been thinking about for a few years now. We kind of fell into it in a way, in that we were asked by the Bill and Melinda Gates Foundation to do an evaluation of the transition of their Apphand HIV/AIDS prevention initiative in India over from the Bill and Melinda Gates Foundation to the government of India. And we started that piece of work back in 2009, and so this sort of train of policy change around transition and graduation of countries from aid has been something that's kind of been at the back of our minds, but I think it's only been in the past 18 months or so that we've really begun to recognise how widespread the wave of donor transitions are, and began to sort of think more systematically about what are the lessons that we've learned from Apphand that could be applied to some of the other funding agencies. I found as I've got older that there are relatively few benefits to getting older, but one of them is that you begin to see cycles and patterns in terms of development assistance. So curiously, back in the early 2000s, I was very interested in what was going on around the scale-up of funding under the Global Health Initiatives, and this chart just comes from work by Maureen Lewis at the Centre for Global Development, and it depicts the massive scale-up. This is just for HIV/AIDS, and I think that that's where we saw the biggest increase in funding between sort of 2000 and 2002 on the one hand, and then 2002 to 2004. So you can see from the sort of dark red plots on the chart that there was very substantial increases in HIV/AIDS donor assistance during that period, and in many cases that funding, particularly in the high prevalence countries, Southern and Eastern Africa, dwarfed national budgets, not just for HIV/AIDS, but for the whole of the health system. So back in 2003-04, one of the things that I was interested in was how are health systems absorbing these additional funds that are flowing into HIV/AIDS, and what kind of impacts is this money having, not just on the HIV/AIDS epidemic, but more broadly on the health system and on treatment for provision of care for other services. And I think what we're seeing now is almost the opposite of what happened back in 2002, 2004, with a sort of scaling back on the part of many funders in terms of their development assistance around HIV/AIDS, but also in some cases around other conditions. So we've been talking about this as a donor transition, and the next slide just gives you a definition of that. So we've been defining sort of transition as the transfer of financial leadership and programmatic responsibilities for a health program from a donor to a recipient according to a predefined plan. I think we've been using the term transition and graduation somewhat synonymously. I think there are slightly different connotations to those two terms. So graduation, I think, is sort of very clearly, well, you've reached a certain set of targets, and therefore often those targets are around GNI or gross national income, and therefore you're in a position now to be able to take over funding some of these programs on your own. Whereas transition may not be triggered in quite the same way. But in terms of the processes that they imply, actually at the country level, I think that they're often quite similar. So that sort of leads to the question of, well, what's driving these transitions? I don't really have any clear answers to that, and I would be interested in some of your perspectives. I think one possible answer is a decline in development assistance for health. And certainly if you look at the Institute for Health Metrics and Evaluation figures, it would seem that in a sort of rather lagged fashion after the recession in 2008, 2009, we did see drop-offs in development assistance for health. But my sense is that since around 2013, actually those funding levels for health have gone back up again to comparable levels to what they were around 2008. So maybe this is part of the explanation, but it doesn't seem to me that it's all of the explanation. There may be a question around political imperatives and to what extent political imperatives are driving this. And I think certainly if you look at some of the rhetoric and the media coverage, actually India springs to mind as one of the countries where there's been quite strong statements coming from some of the senior politicians within the Indian context about the extent to which their country really needs aid, that could indeed be triggering some of these shifts that we're seeing. But again, I suspect that's not the whole of the story. And then I think there's a question around emerging new priorities. So to what extent, for example, has the recent Ebola outbreaks in West Africa and the concerns about the weaknesses in public health surveillance systems and our inability to contain those outbreaks earlier, are they leading to shifts in focus? So you can see that shift happening within the health sector, but also obviously with the negotiation of the SDGs. And I think a new set of issues rising on the development agenda, that could also be part of the explanation as to what's going on within the health sector. So I don't propose to explore those explanations in any more detail, but just to say I think that there are probably a bunch of different reasons as to why transition is occurring. I wanted to use this slide also just to make the point that I think the kinds of transitions that are occurring are actually very diverse, and we shouldn't be treating them all in the same way. This is taken from work that we were doing, really trying to think about how do you go about monitoring and evaluating transition processes in different countries or of different sorts of programs. And we were using 3 different sorts of transitions to reflect on that, one being the Gavi sort of graduation, where what's predominantly Gavi's been providing is funding support to different countries, and I'll talk more about that. But in a way, that's one of the simpler kind of programs to transition. At the other extreme, I think you have programs such as Apphand or perhaps PEPFAR, where not only is the donor providing funding, but they're also providing technical assistance, program management, and often direct service delivery. So when you have a very holistic, comprehensive kind of program, I think what you need to do in terms of transitioning that program becomes a whole lot more complicated than if it's simply a cessation of funding. There's obviously a lot of nuance there between those 2 polar extremes, and we'll talk a little bit more about that, but I just wanted to highlight the fact that the challenges are very different according to what kind of transition you're looking at. So what I had wanted to do in the next sort of 30 to 40 minutes was, first of all, provide an overview of what seems to be current transition policies in some of the principal global health initiatives, and a little bit of the sort of background story about how those transition and/or graduation policies have evolved over time. And I'll look in particular at Gavi, the Global Fund, and PEPFAR. I then wanted to dig a little bit into the Apphand case, which is something that Daniela and I and other colleagues at Hopkins have spent quite a lot of time in terms of evaluating what happened in terms of the Apphand transition. But I wanted to see what we can learn from Apphand about insights for transition more broadly. And so the sort of third and final part of the presentation is really around key policy issues and unanswered questions moving forward. So that's the kind of direction that I'm planning on heading in. Does that make sense to you all? Okay. I should say, perhaps before I move forward, as a caveat, clearly the sort of concrete empirical research that we've done around this is really the Apphand piece. So the early parts, I wouldn't want to present myself as an expert on Gavi transition policies and graduation or the Global Fund graduation policies. This is really plugging into our networks, talking to people in these agencies, but the people within the agencies themselves may have more up-to-date information in some of these points. So the first part, kicking off with a sort of overview of transitions across different global health initiatives, I wanted to start out by talking about Gavi and its graduation policy. Gavi has just updated its graduation policy in July of this year, but pre-July 2015, first of all, they have had a long-standing co-financing policy. So I would say Gavi is one of the global health initiatives that has been thinking from the very beginning about how do we sustain this financially and what should be the contributions of countries who are receiving Gavi financing. In January 2011, Gavi then developed a sort of clear graduation policy which specified that countries who had a gross national income per capita of 1,500 US dollars or higher would be graduated from Gavi assistance, but Gavi would honour any existing commitments to those countries. Just a year later, there were 16 countries that had were identified as crossing that eligibility threshold and having entered the graduation phase. And Gavi now has 24 countries that it's seeking to graduate, and I'll present those in a bit. But I think my sort of reading of it was that Gavi was quite a little bit taken aback at how many countries were moving across this threshold and what it might take to actually graduate them in a way that would help sustain the gains that had been made on childhood immunisation during the Gavi support period. So the Gavi policy was reformulated in June this year, and if you look at the documents, they suggest that the primary goal or purpose of that reformulation was to really ensure that Gavi could sustain, or the countries could sustain the vaccines post-transition within robust health systems, which is interesting that they acknowledge both the need for support to vaccines, but more broadly the systems within those within which those vaccines are delivered. The policy, in my view, has become more complicated than what it was back in July, back in 2012 or 2011. So they classified countries as low income, and then phase one, which is still below the $1,500 per capita. Then phase two, which are above the eligibility threshold, but are still receiving funding. And then phase three, which are fully graduated, but. So it seems that the whole graduation process is becoming more gradual, more step by step than a sort of sudden cut-off. And it's also clear that they're seeking much earlier engagement. So they say that they want to do transition assessments as countries become phase one countries. So as soon as countries are no longer sort of low income or fragile states, and then they will do a transition assessment to try and identify bottlenecks to transition. And then for the phase two countries, the countries which have just gone above the threshold, they've also introduced transition grants. So these are grants which, in the words of some sort of Gavi staff, are almost trying to address the immediate pressing needs of these countries to prepare them for graduation. At the same time, they want to ensure that those countries who are fully graduated and therefore not receiving any financial support from Gavi continue to have access to Gavi procurement mechanisms for a while. And this comes back to a concern about countries on their own being able to negotiate the same level of kind of prices that UNICEF is able to do through its procurement mechanisms. At the same time as rethinking the graduation policy, Gavi also looked at its co-financing policy again to make sure that the country contributions to vaccines were accelerating at a sufficiently fast rate to ensure sustainability. So let's say there's now 24 countries who are in phase two, have sort of gone above the income threshold. This chart is trying to plot those countries both on what their GNI is per capita, so you can see that all of them are going to be above 1,500. But it also, on the vertical axis, reflects the polio coverage in these different countries. So you can see there's a bunch of countries which have very high levels of polio coverage, up above 90%. And I think these countries are perhaps less of a concern for Gavi. But there's also a number of countries such as PNG, Papua New Guinea, Nigeria, which have relatively low polio coverage levels, even though they have relatively high GNI per capita. And the size of, I'm not sure it's a very good measure, but I was trying to get some measure of, well, how significant is Gavi funding in each of these countries? So the size of the circle is the level of Gavi support per newborn over the sort of average over the past 15 years. It's actually a lot of the very small states, some of the small island states that have been very heavy. G20 and those who are not part of G20. And that in turn influences what they are able to apply for. And then they've also got the disease burden is another way of restricting what that Global Fund countries are able to apply for. So for all of the lower middle income countries, all of them are able to apply regardless of their disease burden, but once you become an upper middle income country, and then you have to have extreme, severe or high disease burden in order to be able to apply for Global Fund support. So it's quite a complex picture. They've then also restricted what you're able to apply for. So for the low-income countries, there's no restrictions, but for lower middle-income countries and upper middle-income countries, they're tying some of the Gavi, some of the Global Fund support to services for specific disease groups and specific populations. And this whole policy also changed the co-financing policy as well. So you can see the levels of counterpart financing that the Global Fund is now anticipating from the different countries. It seems that even though the Global Fund updated its co-financing policy in 2013, they felt that there was still unfinished business. So they established a development continuum working group which reported in March of this year. And these were the main recommendations coming from the group, calling firstly for increased differentiation and tailored partnerships with countries in different places along the development continuum. So again, this sort of notion of recognizing that there are very different situations for different countries who may be coming towards a graduation point, and that Gavi needs to be, a Global Fund, sorry, needs to be able to distinguish between these different situations and work with them. They say that the Global Fund should be engaging in sustainability planning from grant inception, so from the very beginning of the grants, and that they need to focus more on appropriate metrics for eligibility and for transition. How do we monitor whether we're looking at the right things in terms of when countries are able to graduate, and also how that whole transition process is working. I felt the last two recommendations were quite interesting. To see the penultimate one is about being more responsive to health needs in challenging operational environments. And I think that really the direction that they were arguing here is that increasingly Global Fund aid is going to be targeted to countries which really have challenging conditions. They're conflict, they're post-conflict, they're very fragile situations. And I understood it as a call for the Global Fund to figure out better how does it work in these kind of situations. I mean, the Global Fund, as you're possibly aware, is driven very much by countries being able to submit proposals, by being able to manage the funding coming in, and perhaps the sort of post-conflict and fragile states are not environments where the Global Fund has really sort of shone to date. And then the last one was about enhancing engagement to contribute to evidence-based health policies and pro-human rights frameworks. This is a theme that I'm going to come back to, because I think that one of the challenges, particularly for TB and for AIDS, HIV/AIDS, is that in the middle-income countries, those are often concentrated epidemics, working with most at-risk populations who may be intravenous drug users, men who have sex with men, female sex workers. And there's often a lot of stigma and policy barriers to working with those kind of populations. So I understood this as asking the Global Fund to step up its game in terms of how it works with countries in those, to help provide services for those people. This working group, in turn, I think, has contributed to the launch of something called the Equitable Access Initiative, which is a bigger initiative being coordinated across Global Fund, Gavi, WHO, World Bank, which is really trying to look at the triggers for graduation or transition and how they can be coordinated across these different development partners. The Equitable Access Initiative only sort of got started, I guess, early summer this year, so it's a little bit unclear to me quite what it will be doing going forward, but it seems like it's a space we should be watching. The Global Fund has commissioned, I think, 10 different case studies looking at transition and how that's playing out in different countries. I don't have access to the findings of that, but I wanted to share with you some other work that's been done out of the Curatio International Foundation in Georgia, where they have been trying to look at countries' readiness for transition, focusing in particular on countries which are coming up for transition. So as you can see, this was work across 4 different countries in Eastern Europe, and the team sort of tried to come up with a set of indicators about what would reflect transition readiness. I won't go into all of the details about the indicators behind these different dimensions of transition readiness, but to highlight that across the 4 countries that they were looking at, in terms of transition preparedness, they found very low levels of transition preparedness. And that was largely in terms of things like, are there plans for transition? Are there agreed responsibilities about what the funder will do, what the governments will do during the transition process? So that seemed to be a problem across all of the 4 countries that they looked at. And also, although it doesn't come out so clearly in this chart, in each of the 4 countries that they looked at, there were concerns about issues such as the legal environment for ensuring services for most at-risk populations, such as intravenous drug users or men who have sex with men and commercial sex workers. And there was also concerns about the level of government commitment to funding policies for these kind of groups. So I think that it's beginning to become clear that this may be one of the issues that is one of the biggest challenges as countries begin to graduate. Finally, in terms of the global health initiatives, I was going to talk just a little bit about PEPFAR. In my view, PEPFAR is one of the hardest of the global health initiatives in terms of really being able to understand what's going on around transition and around graduation. The 2008 Lantis-Hyde Act, which was the act that reauthorized funding for HIV/AIDS, TB, and malaria, was very quite strong in terms of calling for countries to develop compacts between US government and national and regional partners to promote integration and sustainability. It called for the development of transition strategies to ensure sustainability. It called for promoting transition from an emergency response towards a sustained public health and development approach. And it also began to make a distinction between long-term strategy countries, which were typically those with high burden of disease and low income, versus what they referred to as time-limited targeted assistance countries, typically those with low burden and moderate income. After the Act, we saw a number of PEPFAR countries develop what was called partnership frameworks. And we've been engaged, or I'm currently engaged in work sort of looking at these partnership frameworks and how they played out in different countries. During the period 2009 to about 2011, 16 countries developed these kind of partnership frameworks. And for 13 of those, there were then implementation plans that sort of clearly set out how those frameworks would actually be implemented. It seems from what we can ascertain from document review alone that the framework documents generated a sort of stronger focus and attention to issues such as health system strengthening and helped align country plans and what PEPFAR was doing in country. But although there was sort of substantial high-level involvement, so some of these partnership framework agreements were signed by the Secretary of State, by Hillary Clinton, and sort of prime ministers or presidents of the countries involved. Otherwise, they were typically signed by ambassadors, US ambassadors. So they had quite high-level sign-off. But it seems that after the sign-off, there wasn't an equally high-level focus on implementation of these partnership frameworks. And so there wasn't sort of sustained oversight over them going forward. And also our sense is, and again it's come back to the point that I made about the Global Fund, that they appear to have somewhat limited impact on strengthening government support for services provided to key populations. That was an element of many of these, particularly in contexts where there's concentrated epidemics, so Central America, Caribbean, but from what we can see, that wasn't carried forward in any particular concrete way. In the meantime, it seems that there are multiple transitions emerging across different countries. we've certainly heard about these in countries such as South Africa, the Caribbean. I think the South African one has been the one that's received most analysis and focus. And so, for example, papers by Brundage and Katz and colleagues have identified PEPFAR cutting its budget back in South Africa, halving it essentially between 2013 and 2017, and withdrawing from the all direct provision of services in the South African context. Apparently this has led to the closure of specialised HIV treatment centres and the transfer of patients who were previously been treated at the specialised centres to community clinics. And the critiques which these documents put forward is a sort of lack of transparency about timing and the nature of transition, a lack of clarity in the language about what we mean about transition, what we mean about community ownership, and they've also said that in South Africa at least there has been some significant disruptions of service. Finally on PEPFAR, in terms of country operating plans for the current year, FY15, the guidance has, first of all, suggested that there be new country health partnerships. So most of the partnership frameworks that were established back around 2010, 2011, that were meant to provide a framework for PEPFAR working together with country partners have now expired. And countries were asked instead to develop country health partnerships. And there was also something which unfortunately is redacted from the public version of the country guidance, but is known as the PEPFAR pivot cable. And this, as far as we understand, is presenting three different countries, three different categories of subnational units. So taking a district within a country or taking a county within a country and separating out priority districts, which are ones which have particularly high burden of disease and highest levels of unmet need. Maintenance subnational units, which are ones which have got sort of moderate levels of burden of the disease and moderate levels of need. And then what they're calling centrally managed subnational units, which are the districts or the counties which have got lowest levels of need and lowest level of unmet need. And the idea is that PEPFAR will transition from the centrally managed subnational units and will instead sort of shift its resources to the priority subnational units. So I think that we're seeing maybe some transitions occurring within countries, potentially as a precursor to further transitions in the future. So I hope that that's given you a sense of what's going on across these three global health initiatives, and our sense that there's actually quite a lot of transition occurring across these different funding agencies at different levels. You know, sometimes it's a whole country transitioning, sometimes it's subnational units. So I wanted to shift gear a little bit and talk a little bit about what we learned from Apphand and what worked there in terms of the transition, with a view to then sort of taking lessons back to this broader development scene. So for those of you who are not familiar with Apphand, and some of you may know it well, it was a fairly sizable initiative started by the Bill and Melinda Gates Foundation in 2003. And the first 5 years of the program was really focused on building up and operating an HIV prevention program at scale for high-risk groups in India. So it was launched at a time when there was great concern about the spread of the HIV/AIDS epidemic in India, and a sense that this could dwarf what was going on in sub-Saharan Africa. And so there was a real imperative to act really fast. The second phase of the program, which was then from 2009 to 2013, set about transferring the program to government and other implementing partners in India, and also to learn sort of what was best practice about how best to do that. The Apphand Initiative was implemented through a sort of parallel system of NGOs and CBOs who the advantage was that that enabled very rapid scale up. So I sort of said there was this period in India in the sort of 2003-2004 timeframe where people thought, if we don't get a handle on the epidemic now, we're really going to be in a situation sort of running to catch up with the epidemic. So we need to scale up very rapidly. So that was why Apphand chose to operate not through sort of government systems, but through a parallel set of systems. And you can see this sort of played out in this pyramid. On the left-hand side of the figure is how Apphand operated during its sort of scaling up and implementation period. So at the top you had Bill and Melinda Gates Foundation staff on the ground, both at the national level and then one staff member for each of the states who was assigned to support the program. Then at the state level, you had state lead partners who were international NGOs and large national NGOs who provided management support, technical assistance to the grantees. And then at the local level, you had about 170 NGOs, CBOs, who were actually implementing the program at the local level in India. Through the transition process, they were then to hand over their roles to the actors that you see on the right-hand side of this pyramid. So the Apphand or Bill and Melinda Gates Foundation staff were handing over their roles to the National AIDS Control Organization in India. And then the state lead partners, who were largely these international NGOs and large national NGOs, were handing over to state AIDS control societies, as well as to technical support units, which were a new entity which were kind of attached to the state AIDS control societies. The state AIDS control societies, despite their name, are government-organized entities. And then at the local level, you would continue to have NGOs and CBOs implementing the interventions, but they would be hired and contracted and accountable to government actors rather than to international NGOs. And in terms of the transition strategy, the idea was that this was going to occur in 3 different tranches. The first tranche in 2009, in 2009, 10% of these NGOs and CBOs would hand over responsibility to government to contract them and to fund them. And then in 2011, 2 years later, after some learning had occurred from that first tranche, they would hand over another 20%, and then the remaining 70% would go in 2012. So it was very much a sort of graduated set of transitions. And in the first tranche, they sort of sought to hand over the better operating NGOs and CBOs, thinking that these guys are the ones who are most likely to be able to survive on their own. So when we were asked to think about how do we evaluate this transition process, we started out, and this is a slight simplification of our thinking, but we started out with a fairly sort of simple and linear approach, which was there are a bunch of activities that are going on to help prepare this whole system for transition. We wanted to document what were the processes to support transition, and then how well prepared are these different actors at the point of transition, and does that lead to the institutionalization of the sort of practices that Apphand had been promoting after transition, and how does this affect, in the long run, a sustained HIV prevention response? So the next sort of set of boxes that pop up here are the different questions that we had wanted to address through the evaluation that we were doing. And I'm going to walk quickly through each of the sort of different boxes at the bottom to talk briefly about the main elements of the transition strategy, to what extent we felt that there was high levels of transition preparedness amongst the different actors transitioning, and how did that play out in terms of institutionalization and sustained service delivery. Oops. No, right there. So first of all, in terms of the transition strategy, and I think because I want to take lessons more broadly from Apphand to what's going on around transition, I think it's worth pointing out some real particularities of the context in India at the time. First of all, you had a very capable partner government who was willing to take over funding for the transition and had the funding to do that. There was the national HIV/AIDS policies in India reflected a very large scale up in funding for HIV/AIDS from sort of early 2000s to the late 2000s. So the government really clearly had the funding and the willingness to invest it in HIV prevention. And the government was also willing to work with most at-risk populations. I think unlike some other settings, there haven't been quite the same legal barriers to working with female sex workers or men who have sex with men, at least. There are some legal issues around working with intravenous drug users in India. And finally, there was adequate fiscal capacity to accommodate the program. The transition strategy in India, at least on the Gates Foundation side, started very early. I mean, talking to people there, they said we had this in the back of our minds from the very beginning. And I think part of what explains this is that the Gates Foundation, by and large, doesn't do service delivery. This was quite a departure from their usual way of operating. I mean, many of you are probably aware that a lot of what the Gates Foundation does is innovations, technological innovations, supporting the rollout. So it was kind of unusual for them to engage in this scale of service delivery. And the people in the Gates Foundation office in India felt they really needed to demonstrate that it was possible to scale up and then get out of service delivery to hand it over to local partners. So they started planning early. The first document that describes the transition strategy goes back to 2007. They had a fairly clear transition strategy. It certainly evolved over time, but the Gates Foundation and the government of India stuck to the timelines that were set out in that strategy. And that was most noticeable in the first transition tranche 2009, but everyone at the time was saying, we're not ready, we only identified the NGOs that are going to transition just before the transition took place, and yet nonetheless they pushed ahead with that transition, which we thought was kind of important. The key elements of the transition strategy included aligning services. So remember that they were delivering services through a completely parallel system. They had different modalities for the clinical services. They had different types of management tools, different health information systems. All of that needed to be aligned with government before they could transition it. They also sought to build capacity across all of the different levels of the system, from the NGOs all the way up to the National AIDS Control Office or organisation. And they also sought to promote a supportive policy environment, in particular by being very engaged in the development of the National AIDS Control Policy 3. I wanted to start out by just giving you a sort of historical perspective in terms of what happened. Our sense is that the first transition, the 2009 transition, was problematic. As I noted already, there was a short time frame, there was a lack of collaboration between Apphand and government, and you see that we did sort of qualitative research as well as a more quantitative data collection. And in the interviews, there was a lot of discussion and sort of blame throwing between the different partners about who did what right, who did what wrong. It was really clearly an uncomfortable relationship at that point. And there was a big time delay from when the transition took place to when resources actually started flowing from government to the NGOs providing services. And there was very limited post-transition support from the Apphand side. So once the transition took place, the state lead partners often thought that they would be able to continue to provide some support to the NGOs that they had been working with. And in some instances, government turned around and said, no, we don't want you providing any more support. They're ours now. It's within our remit. So those kind of things hadn't been negotiated and discussed in advance. The second tranche, I think, was much improved, but it was quite a small transition round. It was only 20%, but we saw strengthened relationships between Apphand and government over the intervening 2 years. They had begun to negotiate and talk more. We saw transition managers put in place by Apphand across all of the state lead partners, longer periods for preparation. They built up buffer stocks so that if there was a delay in terms of getting supplies of condoms and other drugs into essential commodities to the TIs, and then they had stocks in place. And there were very clear agreements about post-transition support that had been negotiated in advance. Finally, the third round of transition, I think people sort of thought, well, the second round was bound to go well. It was only 20%. We knew what we were doing by that point. But 70%, this is on a completely different scale to what we've handled before. But actually, by and large, it seemed to be handled fairly effectively. There was even earlier preparation for the different TIs. There was strong collaboration. They developed something that they called the Common Minimum Package for Transition, which was it was a spreadsheet, but it walked through all of the different steps that needed to be implemented at different levels of the system to prepare people for transition. And post-transition support was institutionalized in terms of agreements. I'm aware that I'm running out of time, so I'm going to try and speed up a little bit. We looked at the alignment of clinical and non-clinical aspects of the programs. In terms of clinical aspects, an awful lot of work went into ensuring clinical alignment prior to transition. It entailed things like shifting services that were provided from the NGO sites themselves into the government system. The new models for service delivery relied a lot more on government services, and government, in many cases, conducted quite a lot of sensitization work amongst the government providers to prepare those government providers for more the kind of services that they would need to be providing to reduce stigma and discrimination, particularly for some of these at-risk populations. The services were also much more focused. So before So, big picture, I would say that a lot of energy went into the alignment and to the preparation for transition. And overall, we felt that the TIs were relatively well prepared for transition, but it certainly got better over time. So the next thing that we were interested in looking at was how did this affect what happened after transition in terms of the maintenance and the routinization of the different services and the kind of practices that were there before transition. I'm not presenting to you a full picture here, but one of the things that we found that was really interesting was that we went back to the TIs, to the programs, the targeted intervention. So I'm using this term TI, it means targeted intervention. And we use it almost interchangeably with NGO or community-based organisations, because it was the NGOs who were delivering the targeted interventions. We went back about 12 months after the transition had took place and asked the TI managers, what has happened as a consequence? To what extent are you still performing these practices in the same way as you did them when you were managed by Apphand? What really surprised us was the high level of change that had occurred in the 12 months since transition, but also the fact that by and large the managers whom we spoke to saw these changes as good things, that there had been positive innovations that had taken place in the system. There are a few, I've given you some of these positive examples here about the use of micro-planning tools by the outreach workers, as well as performance management of the outreach workers. There were some more negative findings. This came in particular around weaknesses in funding and supplies. So one of the problems which was noted across a lot of the NGOs was stockouts, issues around cash flow, that they weren't getting their funding from government in as timely a way as they had received from Apphand, and the fact that transition had led to lower budgets for everyone. Although I think that there was a sort of ongoing debate as to what extent had those lower budgets really damaged services or not. We can talk more about Our sense from the data that we had was that service coverage had been sustained. So on this chart, which is looking at the average percentage of the high-risk groups contacted per month by the peer educators, the vertical line represents when the transition took place. And you can see that, by and large, that the service coverage was maintained. And then this one is actually about the average number of condoms distributed per high-risk group per month. So service coverage seems to be sustained as well. But what we found was that our transition readiness indicators, those NGOs that seem to have been very well prepared, this positively affected service coverage after transition, but we weren't able to link the institutionalization dimension of this. So we thought that transition readiness would mean that those NGOs were able to institutionalize the practices better, and that would lead to sustained service coverage, but that doesn't seem to be the overall flow there. There's also a big but around communities' experience of transition. So we were doing qualitative data collection, case studies of transition, alongside these sort of more structured interviews with TI managers. And there were clearly different perspectives between the communities and the people managing the projects. Community members expressed much more negative views about the effects of transition on community mobilization and outreach. And what happened sort of post-transition as part of the budget cutting was much less investment in little things like tea and biscuits for the people who came to the drop-in centres. That really had a sort of outsized impact in terms of the savings that it meant. People were very upset to see some of these things discontinued. And there was also a sort of shift in clinical services to being mainstreamed in the government system. Some people felt, well, some of those communities served felt that this is a good thing because it means that I'm treated like everyone else amongst some of in the government system. Others felt very sad that they had lost this kind of special safe space that they had previously had in the drop-in centres. And we also saw, I think, differences between different communities as to how they reacted to this. So, for example, some of the commercial sex workers could go and receive services within the government facilities and not feel stigmatized, whereas perhaps some of the transgender communities who had previously been served, it was harder for them to seek care in the government system. So you really need to look at some of these issues at a very granular level. We also, part of what Apphand have been trying to do was to stimulate community mobilization and sort of organization. And it was fairly clear that the initial transition strategy did not fully address community mobilization and government's capacity to take on this role. In practice, it seemed that government was not well placed to take on community mobilization activities. It certainly had less funding in its budget for these kind of activities than Apphand had. There was relatively limited support from the government side to support these kind of services, and they had less expertise in terms of supporting community mobilization. So the Bill and Melinda Gates Foundation introduced a third phase of the project, which provided funding. I'm just going to take a couple of minutes to go very quickly through some sort of final reflections. We tried to derive from the Apphand experience some key lessons for transition success. I think many of these will look quite familiar. We talked about extended timelines and phased transitions, substantial investment in preparing the NGOs and the targeted interventions for preparation, the commitment to transition on both sides, strong communication to stakeholders, and the development of trust over time, as well as this idea of providing support after transition had occurred. Many of these are now written up and published in documents and in articles, and I'm happy to share those with you. But I just wanted to return briefly to sort of broader implications. It seems to us that transition is fairly widespread at this point, reflecting whether it's shifts in priorities, shifts in balance of power. And the global health initiatives are gradually strengthening their policies and approaches. And I think that they're both more clearly articulating what they're doing, but also having more incremental approaches. So it's not a one-time, all of the aid ends. It seems to me that many of the sort of principles of good aid that you would see embodied in the Paris Declaration, things around ownership of transition, alignment to make sure that donors are aligning their programs with country programs, and harmonization between the different donors so that they're acting in a harmonized way, so that we're aware that different donors are withdrawing funds at different times. These kind of basic principles of aid effectiveness are really important in terms of donor transition, not just in terms of routine practice. My sense is that Gavi and Global Fund are increasingly clear about how they are approaching transition. I think PEPFAR is still seeking that kind of clarity. And I would also say that there's a real learning agenda here that we've really begun to barely scratch the surface of. I wanted to leave you with a few outstanding questions. I think there's a big question about what do we do where the challenge is not so much lack of funding or lack of capacity to deliver services, but a lack of political will to deliver services for particular communities. Post-transition should be support, what should be provided and for how long. You can see Gavi and the Global Fund beginning to think about that. And also market shaping role. Many of these global health initiatives have played a role in bringing down the prices of commodities. How do we ensure access to low-cost commodities as some of these actors begin to step back from funding directly in different countries? I will stop there. I do want to just put this up as a thank you because this presentation has been informed by lots of different people's comments and contributions. So maybe I can just leave them up there for you to see the different pieces that are fed into it. Thank you very much. Sorry for hurrying at the end.
Thank you, Sarah. Thank you for a fascinating presentation. I felt that we work a lot on nutrition here, which is facing a lot of similar issues. But it's really at the beginning of these huge investments coming into countries, and we need to really be thinking about how we can plan this from the beginning and learn from such lessons here. But also potentially a lot of lessons for the kind of direction of bilateral aid more generally rather than sectoral specific initiatives. So I think a lot there of interest. But we're going to take some questions from the floor. I'm just going to ask that if you could speak into the microphone as we pass it around so that people on the live stream can hear you as well. So if you just indicate to me if you have a question, we'll take the discussion forward that way. So I have one from Henry to start off, and Hayley there as well. So. Pass that back, Henry. Thank you.
I was interested in Sarah's comment right at the start about living long enough to go through the various cycles, and of course one of the big cycles in the health sector is the vertical versus horizontal programs, or integrated programs. These huge investments came about mainly driven by, I suppose, by AIDS. That was the kind of driving force, and then TB was included and malaria was included. And that seemed perfectly reasonable while this was being funded by donors, because then you were, as it were, international priorities on these areas, which were shared by many national governments, obviously. I just wonder about the extent to which, when you go through this transition process, whether one would like to see those priorities maintained, or whether it's now reasonable to see shifts back to national priorities. What we did see a lot of, it became very attractive to be in one of those three areas. I remember working in Cambodia on the government, the health sector information system. And I remember spending 3 weeks there, and nobody from HIV/AIDS spoke to me. They couldn't care less about the government health information system because they'd had their own, and it was very well funded, and they were all getting paid rather more than in the government sector. And there was this sudden switch between are you in or out in terms of which kind of health service you're providing. And I wonder if it would be reasonable to expect some sort of shift back towards national priorities and away a bit from international priorities.
Thank you. If we take Hayley's question, we'll take two questions together. So,
thank you. I was really interested in your reflections at the end, and I'm still sort of processing it, but I think in particular there's a sense in which some of these externally funded initiatives can give money for innovation in systems, and then your reflections on what factors meant those practices could be sustained after transition. And I guess it made me reflect partly on what I know from the South African setting, where government policymakers I know are really frustrated by precisely this kind of model of parallel systems, say in health information systems and so forth. And I was wondering how much sort of reflection there is on whether, I mean, it depends on the different agencies, but whether a language of partnership from earlier on might be a more sustainable way than the kind of enormous energy that seems to go into establishing one way of doing things and then moving on. I mean, I understand that at the end I thought your reflections were really interesting in terms of what kinds of services perhaps needed to be externally catalysed, such as with vulnerable populations. So I can see their sort of trade-offs, but I just wondered if you could comment more on that.
I think there are actually two quite closely related questions about, and in a way one could be asking, to paraphrase them, did these global health initiatives come in and actually distort what was going on? And if so, maybe we should be quite happy to see some of them beginning to scale back and leave countries. I think it's actually a really mixed picture in terms of what's gone on out there and to the extent to which there was distortion and how that changed over time, because I think that they've also learnt over time, that creating entirely parallel and separate systems is problematic. Though I think one of the real challenges now for a group such as PEPFAR is this, there's a dwindling budgets, and yet there's still a lot of focus on achieving results. And yet we know that if you really want to sustain those results over time, you need to build the health system in which they're embedded. So it does seem to me like it would be sensible to think more about these questions from the very beginning, and I'm not convinced that everyone did back in 2003, 2004. At the same time, I do think that in most cases there are very valuable elements of each of these initiatives which, on an empirical basis, you would say they are offering cost-effective, valued services that the nation should value. Certainly, if you look at Gavi, we know that immunisation is a highly cost-effective service, and I think that many of the HIV/AIDS, TB, and malaria services are also fit into that box. So I think it's an important question to ask about: will these services be sustainable over time, and if so, how? But it perhaps should have been asked much earlier in the overall process. I don't think that's a very clear response to either of you, but sort of acknowledging that there's a difficult set of issues here that need working through.
The is partly what's quite fascinating.
Yes, and they've all operated very, very differently in countries, and again that's changed over time as well.
Great, thank you. Any more questions from? Yes, Abbas, and okay, I'm going to ask a question as well. So Abbas, you first.
Thanks. Thanks, Sara. I have two kind of related questions, both relating to the local conditions of Apphand. One was so while it was a first for Gates Foundation to fund a implementation of a program, definitely it was also a first in many ways for the Republic of India, because they never had an external agency coming, taking over and delivering a nationwide program, of such a scale ever before. So I was wondering if the initial negotiations between Gates and Government of India, what were they like? How were they allowed entry in the first place at such a massive level? And secondly, if that had a bearing on the transitioning out or the phasing out of the Apphand project. And because it's still they're still facing problems in different states, right? And the second and related question is, obviously there's a lot of diversity within India, and you mentioned one bullet about how different states compared relative to each other in terms of the transitioning out. I noticed Tamil Nadu quite low in the rankings, which is kind of surprising to me. So I was wondering if you could elaborate on that, and whether that was also the diversity in the state picture also is a reflection of the initial contrast and negotiations between the Apphand and the Government of India.
Great, thank you, Abbas. And I had a question as well, which was kind of inspired by some of the earlier questions, but also in terms of what these global health initiatives are doing, is there any harmonisation between them in terms of these graduation criteria? And I wondered whether that would be a good thing or a bad thing, because I was also wondering whether if there was a sudden, if a country reached a certain stage, and then there may be a sudden kind of synchronised drop in their health. Exactly. So I'd be very interested to hear a bit more about that.
Yeah. So I'm not sure that I can fully answer your question, Abbas, about what enabled Apphand to have such access. I can make some guesses, and if Daniela wants to add from her perspective, and then she should do so. I think, as I tried to sort of say in the presentation, I think it was a very particular time in India in terms of what was going on around HIV/AIDS and what people were projecting could happen. So I think senior policymakers perhaps might have been more open to external intervention on this issue, thinking that it really is going to be a challenge for us to scale this up as quickly as it needs to happen. I also think that the leadership at NACO at that time was fairly open, and I also think that from the Gates Foundation side, the Gates Foundation office in India was unusual. They had a lot more autonomy than Gates Foundation offices. I mean, they didn't have many offices outside of Seattle, so it was unusual to give that much authority to a country office that was then headed by someone who was very senior and very well respected. So maybe it was that sort of set of personalities as well as the time that this happened that gave them that kind of access. There were differences between the different states, and I think I didn't focus on those here because I wasn't sure how much it would contribute to this particular discussion. But it played out very much according to what were their strengths and weaknesses at the beginning. I wouldn't have said that Tamil Nadu was particularly a weak state. Obviously it's known for having a strong health system. And in fact, I think one of the strengths here in Tamil Nadu, from what I can remember, was the fact that they had done an awful lot of sort of community level empowerment. And on the government side, there was also a big investment in sensitising government health systems to be more prepared to receive people who had previously sought care from Apphand. So I think if I gave the impression that Tamil Nadu was more problematic than other states, that is not the case. But the situation varied state by state and on dimension by dimension. About the harmonisation across the different graduation criteria, I think is a really important question, and actually it was one of the sort of bullets that I was whisking through at the end and sort of trying to figure out how you could summarise very quickly, because I think that people are worried about the falling off the cliff phenomenon. There's certainly quite a lot of talk going on between Gavi and the Global Fund, and that's perhaps easier to harmonise because they're both sitting in Geneva. This Equitable Access Initiative, to the best of my understanding, is trying to look at criteria for graduation across different agencies, but also trying to think about ways of measuring graduation or transition readiness and not just looking at GNI per capita. So, for example, I think Gavi's been thinking about its health system strengthening window, and are there measures of health system strength that you could use to trigger access to that window? But a lot of the time the problem are that we haven't got solid, reliable indicators of some of these things that we would really like to get at in terms of that might signal that we're ready for the withdrawal of funds. So I think it's a watch this space as to how they will coordinate. And also it seems to me that there are other actors such as USAID, the bilaterals, who are thinking about transition and graduation, and I'm not sure to what extent the conversation that's currently occurring is really including all of them versus a subset of them.
Thank you. And unfortunately, sometimes it's more politically
Yes.
driven than we would like. Yes.
Yeah, that's natural.
Yeah, thank you. Any further questions? Yes, sorry, Sophie. Do you mind passing it?
Yes, thank you for the presentation. I was just wondering, out of the case of HIV/AIDS, if you have any knowledge of other cases linked to other diseases, such as, for example, bird flu or Ebola, which are happening in a more short term and acute epidemics rather than a pandemic such as AIDS that is happening everywhere and such a long-term thing. And also, I just wondered if there was any case where you could see the inclusion in the program based on not only income of the country, and you talked about burden of disease, but also the health system capabilities, because I think if you look at different countries, you might have different capabilities in different parts of the health system. Thank you.
One more.
Thanks very much. I was in Ethiopia sort of 2002 to 10 as those big tranches of funding were coming in, and saw some of the negative effects of those. And I'd be very interested to hear. I don't know how far you've got with feeding back to the Gates about what you found. I know they're unlikely to be funding intervention in the future, but is there anything that you could put to them or other large funders about initial approaches that would make transition easier later on?
The last one, Nick.
Oh, okay. No, we've time.
A slight shift, but it may be related a bit to Gail's question, but I can get it in. I mean, I guess I'm interested in sort of the question of that identities of these programs, and you still refer to it as Avalon. And I wondered if you plan to go back, say, in 5 years' time, whether... well, I mean, of course, it's very interesting to think what would have been sustained and whether even the gains you saw initially have been sustained, but whether people still have a sense of it as that, and whether, I mean, Henry's point, whether national priorities might actually have really shifted, or alternatively, if there's been sort of interesting cross-learning to other parts of the services beyond what used to be Avalon.
Very good questions.
Yeah. Do you want to comment on any of these questions, Danielle? You keep sort of waving no at me.
No, because I'm nodding thoughtfully yes. It's really along the lines of the things that we've been thinking.
So let me try and take a crack at them. One of the things which I listed as a sort of thank you here is that we've been hosting a series of conversations in Washington with the Results for Development group about sustainable financing, and actually the last one, so we've worked through several different sort of transitions. We looked at Gavi, we looked at Apphand, we looked at a series of family planning transitions that USAID did in Latin America earlier. And then more recently we've looked at polio, because we're very aware that with the polio sort of end game coming, people are thinking about, we've had all these resources that we've built up to end polio towards eradication. What's going to happen to them when we've actually eradicated it, and how should these resources be repurposed? And then we also had a conversation around Ebola, which was one of the we thought might be interesting because it is at the beginning, it is an emergency response, and as the outbreaks are coming under control now, I think there's more discussion about how do we transition from an emergency response into a sustained response. So, and I think that the interest in looking at Ebola in particular goes back to this, well, what can you learn at the very beginning that's going to help you 5, 10, 15 years down the line in terms of what needs to be done. I think one of the things which for me came out of the Ebola discussion was often we know the things that we need to do. We know that we need to work through systems. We know that we need to develop plans that are, co-owned by government or owned by government, but supported by the funder. But there are often so many bureaucratic barriers to actually being able to do what we know is right. There are obstacles that bureaucracies put in our way to be able to do that. So I felt from the Ebola conversation I heard quite high degree of frustration at not being able to do some of these things better because of the fact that USAID only gets funding coming for 1 year at a time, so it's difficult to have long-term plans and all of the rest of it. I think that the polio example, I wasn't there, so I was hoping Daniela would chip in, but she's not going to do this. But I think the polio example was also interesting because there was a big debate about whether the eradication campaign was actually strengthening immunization systems in the countries concerned, or whether the fact that it had been run as a very sort of vertically oriented program focused solely on polio eradication actually meant that there hadn't been broader benefits, and it was unclear how this infrastructure was going to sort of be integrated into the health system upon eradication. So you also asked about the sort of measures of health system strengthening and how they could be integrated into transition. One of the big challenges really is thinking through what indicator is a good indicator of the overall strength of a health system. I was in conversations at Gavi a couple of weeks back about should they use indicators of health system strength as a way to help allocate their health system strengthening funds. And it's difficult to know how to approach that. If you look at something like number of health workers per capita, doesn't really tell you that much about the overall strength of a health system. You might be able to look at something like maternal mortality. That's sometimes suggested as an indicator of health system strength, but it reflects a lot of other things as well. So it's difficult to find the right indicators so that you're transparent about what you're doing. In terms of the Apphand plan to go back and look 5 years later, we're actually actively debating that. We have just a limited amount of resources left over. We did our last round of data collection in 2012, end of 2012, was it? So, and there's actually been quite significant shifts very recently in India. Any of you who are following India, with quite a lot of money being taken out of the national health budgets, and people who work on HIV/AIDS are saying, we're already seeing big shifts in that program take place. So we thought that it would actually be very interesting to go back maybe next year to do some smaller scale work as to see what has happened. But it does come back to, naturally if there's once donors are out of the picture, governments will shift their resources to match their own priorities. Is that a good thing, a bad thing, inevitable, something we should care about, we shouldn't care about? I think are questions that we're still working through.
Right, so thank you. A fascinating seminar. Some really great questions from the floor as well. So it just remains for me to thank you all for coming in, particularly to Sara for giving us such an excellent presentation. So thank you again.
Thank you.